Good evening, everybody. Thank you for joining us for the Midwestern Vascular New Horizons webinar series for this April. Tonight, we're going to be talking about hot topics in PAD sponsored by Cook Medical, and we thank our sponsors for their gracious support of this series. I'm Trista Babrowski from the University of Chicago. I'm joined tonight with my co-moderator, Joe Morani, and we have a great group of speakers tonight who are going to really delve into everything we need to know about what's new in the management of peripheral arterial disease. Our first speaker is Greg Weston. Greg is an assistant professor in the Division of Vascular Surgery at the Indiana University School of Medicine. He's also the medical director of the Comprehensive Wound Center. And Greg's going to speak tonight about pedal access, when and how I do it. Greg? Greg, I think you're muted.
Sorry about that. Thank you all for having me. Thank you, Dr. Bobrowski, for the introduction. And I'm glad to be here talking about complex endovascular access and tibial pedal access in particular. So I come to this with the expectation that this is something that many people have done, but many people are skeptical of. And I just want to sort of introduce the topic and go over some techniques that may be helpful to you if you're thinking about exploring this. So in terms of disclosures, I direct a wound center. I am very invested in peripheral arterial disease. I really don't like performing amputations. Also, I'm someone who will spend hours and hours and hours on an angiogram. So if you are someone who wants to be done with your angiograms on the hour, what I'm going to describe may not be your speed. I don't have any conflicts of interest. So today I'm going to break this down into a couple areas. First, why should we be doing this or thinking about it? Second, thinking about whether there's any evidence to support or dissuade us from this. And then mostly about a few tips for how I've gone about doing this. And then a few sort of pitfalls and danger points to think about. So why should you be thinking about pedal access? In people who have, the standard transfemoral access is good for most people, but in hostile groins, people who've had prior bypasses, flaps, people who going up and over might be difficult because of complex aortoiliac anatomy, like an EVAR, or some infection in the groin, other reasons why you might, a really large pannus where you're worried about, or really deep artery in the groin. Those are all reasons why you might think that your increased risk of complications and difficulty go up with your femoral access. So an alternate access may be useful. In terms of getting across a lesion, antegrade crossing may not, meaning not how you access, but how you cross the lesion. If you're crossing it in an antegrade fashion, that may not always be successful. One way of looking at this has to do with looking at the characteristics of the lesion, which honestly I haven't found terribly useful. But theoretically, if you think about this, some lesions will have a hard, dense cap at the proximal site, but might not have that on the distal aspect of the occlusion, and so might be easier to cross from one direction or the other. If you couldn't cross from above, it might be easier from below. You can also think of it as an adjunct to antegrade access. So I'll describe this a little more later, but thinking about crossing as not just a single wire going across a lesion, but other techniques that involve two wires, maybe two balloons, maybe other devices could be useful for getting across complex lesions. So is there any evidence about this? I'll say that this is somewhat limited. It's mostly limited to people who are probably more enthusiastic about the technique. But I would start with the idea that we all know that there are some lesions that we can't cross from above, that some of these will be uncrossable in any situation. But if you have these infrapopliteal in particular, but sometimes femoral lesions that can't be crossed, and that number seems to be somewhere in the maybe 10 to 40% range based on a couple of studies. And in the couple of studies that I've seen that try to figure out how often those can be treated with retrograde access, I've seen numbers in the range of 50 to 80%. Now, some of those are probably biased by operators reporting success, but it's not, as far as we can tell, 10%. It does seem like a reasonable number of these can be crossed with an extra retrograde access. And again, acknowledging that this is limited evidence, there's some evidence for reasonable complication rates. Most of us, when we think about this, are understandably concerned about trashing a tibial artery, losing our bypass options, and in systematic review of cases that have reported retrograde access, the rates of flow-limiting dissection, perforation, distal embolization, significant hematoma at the access site are all under 5%. So even if that is a vast estimate by skilled and enthusiastic tibial access operators, I think it demonstrates that in the right hands, this can be done relatively safely. So when I do choose to do tibial access, I think the first thing to be thinking about is deciding on your strategy for access, because it's not one size fits all. You might be doing primary or only access of a tibial or pedal artery, or you might be using it as an adjunct and having access both from the tibial artery and from the contralateral femoral artery or the antegrade femoral artery, or maybe you're coming from the radial artery, some other access point. Also, it's important to think about which tibia you might access. You want to get things set up so that you can see all the way down to the foot. When I first started at my current job, I had often go into a room and have difficulty getting the hybrid room configuration to get the C-arm all the way down to see the foot. It would see kind of to mid calf, and then they would say that's just as far as it can go. And so think about your own setup. You could do something like position a patient with their feet towards the typical head position in a hybrid room. You could do something like move anesthesia to the other side of the hybrid table. It's possible in most hybrid rooms, so that you have the C-arm coming from the patient's right, or the hybrid C-arm coming from the patient's right rather than the left might give you a little extra distance. But more so than when you're doing other access, you want to make sure that you can see all the way down to the foot, and ideally also get multiple views, so that you can get like a dorsal view of the foot or a lateral view of the foot. And then probably most important in accessing a tibial is thinking about how to actually get in and get a wire in. So I prefer ultrasound guidance, and that's what I do, I would say 100% of the time. But the ultrasound for a small tibial vessel, the hockey stick probe, can be very useful because you get better resolution. And in many times, having a longitudinal view to follow the needle and the wire into the vessel is more useful than in your transfemoral access. It can be especially with these calcified arteries, you might not get an artery to needle to nicely just poke into a vessel. You're often going to be having to get it into a very diseased vessel and have a small lumen. So you and you may not get blood return because this may be a situation where it's either an occluded vessel or a very low flow. Fluoroscopy guidance is an option. I've heard this described. I don't think I've ever done it, or maybe I've done it once. But that has been described for heavily calcified vessels, and especially for something like if you were going to access the perineal artery, that may be an option, but not my strategy. When you're using ultrasound, you can, especially with most of these vessels are going to be calcified in these situations, so compressing the veins with an ultrasound can be useful. It may be useful to go through and through the artery, then slowly withdraw and advance the wire as you go to see it under ultrasound go through the vessel. The artery may not collapse easily if it's heavily calcified and chronically occluded or very low flow. And even an occluded tibial can be useful as an access point because you might be able to pass a wire up through it. And then if you're trying to cross something like a complicated popliteal lesion, it may be useful to get across and then avoid having any of the complications happen to your dominant runoff vessel. In the interest of time, I'll skip this for now, but using balloons and other devices can be useful to have the two access points. And thinking about closing the artery is always an important point and a common question. I think you should do this with pressure. If that doesn't work, I would try pressure and gentle pressure. Some people do describe using compression devices or internal balloon control to try to occlude the artery from the inside. I've had good success with direct pressure. You should be accessing an area where you have access to the artery. And I always worry that internal balloon control, when do you reverse the heparin and would you cause clot at the time when you're doing that? So I just use direct pressure. Things to worry about: single vessel runoff. I would be very careful or not do this. Putting a large sheath into a small artery. Again, many times you could do this with either sheathless access or just a micropuncture access and not putting a significant sheath in, or you could use a low profile sheath. And I am very wary of perineal artery access. And so that would be something to be concerned about. And always a question to have in your mind is, why am I doing this? Is this something that's going to be helping me, or should I really just be doing a bypass? So in conclusion, I think tibial retrograde access can be safe and effective if you do it right. Having a good access ultrasound is essential and is different from doing transfemoral access. So getting experience with the ultrasound of a tibial artery will really improve your rates of success. And always be mindful that even if you don't want to be doing a bypass for this patient, that might be the end result if we're trying to get limb salvage. So be sure to save any tibial artery that might be the best bypass option.
All right. Thank you, Dr. Weston. So we encourage everybody that's online and participating today to please put questions in the Q&A box. And we'll do our best to get to as many of those as we can at the end. Just a brief question for Dr. Weston. In our own practice, we originally got the pedal access kit that comes prepackaged with a small, shorter entry needle that I find a little bit easier to get into the tibials without using the normal kind of longer micropuncture. And we kind of also really liked using the CXI catheters. They tend to have a little bit more push for us, and they do have some shorter lengths, which are nice in the lower profiles. I don't know if you have any other kind of tips and tricks on the specific types of equipment other than low profile, or types of wires to use.
Yeah, so the Cook has a access kit that is essentially a micropuncture sheath or a micropuncture catheter to which you can attach a side port. And that comes, like you said, with a small short access needle, or the low profile sheaths. Also, many of them come with shorter needles that are designed for radial or pedal access. Both of those, I think, are useful, not having the long normal needle that you'd use for femoral access. So I always use one of those needles. When you get access, using an 014 or an 018 wire, I think is going to be essential for accessing a tibial artery. And I often just go right to the long wire. I'm often using a Glide Advantage wire, but whatever your preferred 014 or 018 wire would be, I'd often just go straight to that rather than using whatever wire comes in the kit, and then using a unassociated catheter. Like I said, you could be sheathless for a lot of this, or even if you're doing it, you can fit a CXI 014 catheter through the Cook micropuncture sheath or catheter, whatever you call it. So even without upgrading to a forefront sheath or a low profile sheath, you can at least get a catheter and wire through if you're using 014 system. And that, if that's enough to get across, if you have access from another point like the contralateral femoral, then you can always treat from there without upsizing your tibial access.
Thank you. All right, so next up, we're going to move on to Dr. George Pontikis. Dr. Pontikis did his training at Loyal for general surgery residency, then UT Southwestern Medical in Park Hospital for fellowship. He is currently at the Dooley Health and Care Center in Naperville, Illinois. This topic we're going to be talking about now is the use of covered stent devices in aorto-occlusive iliac disease.
Give me 1 second to load that up. So thanks for the introduction and the opportunity. You guys all hear me okay, hopefully? Yes, all right, great. So what I'm going to talk about, I don't think is revolutionary, if you will, in terms of the use of covered stents in aortoiliac occlusive disease. But it's kind of demonstrated its importance and evolution as, I think vascular surgery is at a crossroads, if you will, as far as a lot of the open surgeries still viable and strong, but with endovascular improving with each iteration, I think we're continuing to push the envelope. So it's up to us to kind of basically check in and see how we're doing with that, and then look at the emerging technologies as we do continue to improve. So I don't have any financial disclosures. So the evolution of aortoiliac occlusive disease, I mean, been described from the time of Lariche, and for patients that were had debilitating claudication, CLTI, they were committed to some pretty invasive procedures: aortic endarterectomy, aortoiliac and aortofemoral bypass, as well as extra anatomic bypass when they weren't candidates for the other two due to their comorbidities. As we know, vascular patients, we take care of the sickest patients in the hospital, undoubtedly. So, even with open surgery, we've demonstrated continued improvements in techniques, materials, post-operative care, yet it still carries significant morbidity and mortality given our patient population. So, this is what this is what made it a lot of us go into vascular surgery, but then it's kind of the evolution of how we progressed to the catheter-based therapies. And I included this slide here in terms of I recently was at the Cook plant tour, and I love this picture on the left where it was Bill Cook meeting Charles' daughter at the radiology conference in '63, and they daughter noticed his Bill Cook's catheter construction and wanted to take it one step further. So he borrowed his Bunsen burner and materials to come up with the first generation materials for it, and you can see the angiographic result, and the patient that was described with healing of the wound. So, with that, endovascular was kind of born, and we've been improving it each year since then. But in vascular, we try to come up with good materials for guidance, and based on the task guidelines, the goal is to provide, updates every so often, and look at the guidelines and look at the, assess all studies, references, use experts to come up with one kind of consensus. And with endovascular, they made improvements, but it wasn't the answer due to the high risk for stenosis during that time period. And what you see here is on the right, where we, described that task A lesions were good for endovascular therapy, task D were just deemed open surgery, and B and C is where we kind of see the gray zone, with B focusing more endovascular first and C focusing more on open surgery. But the importance to emphasize is this is back in 2007, and I think we think back to what's come up since that time. It's pretty remarkable, and how much we've progressed, and therefore we have to kind of analyze that to see how we've improved. So with that, with the endovascular revolution, there's the kissing stents, and then eventually with a lot of techniques evolving to CRAB, we've one aspect is we refined the technique. We've kissing stents were very good initially, first iteration with bare metal stents, and then using with CRAB using covered stents, and then some studies demonstrating in vitro studies anyway that there's better flow dynamics, and with this there's less extrusion of thrombogenic material to enter towards the lumen, and therefore the idea is to see patency rates comparable to open surgery. So techniques have improved. And then we look at with this group in the European Journal of Vascular and Endovascular Surgery in November of 15, these patients now, instead of for endovascular first strategies for task C and D lesions, these were over 80% were treated were task D lesions, and with excellent patency rates that rival open surgery. So even with just 8 years right there was significant improvement in this group coming up with the technique with CRAB. But with that, we also have dynamic improvements with catheter-based therapies with wires. Both with wires, with catheters that you see here. These are two of my favorites as far as the glide wire advantages was mentioned earlier by Dr. Weston. I love the Navicross. CXI is excellent as well. These braided catheters that allow us to get it through some difficult lesions. Reentry devices, Pioneer on the left, BBEC, which Cook has recently gotten the distributing rights for that you can do now with pedal access with 4 French sheaths from below is pretty remarkable. Rotarex for this is from Bard, where with debridement and optimizing the lumen to get better results for covered stents, and then the covered stents themselves. So iCast on the left, Vibon on the right that you see here, they're kind of the old stalwarts, if you will, of this, but with VBX and now low profile VBX, these continue to just the technology continues to improve. So the idea with covered stents is you can be more aggressive to achieve greater luminal expansion. You kind of get more brave. I know I'm guilty of it. Get more brave with when you have covered stents, and to achieve the best luminal gain despite any extrinsic plaque. The idea with covered stents is you have less thrombogenic debris entering through the stents that would compromise the patency. And with that, I guess, why are we pushing the envelope with that? We all love doing aortobiofemoral bypass surgery, which has excellent patency rates, but the reason is patients just recover quicker. They're shorter hospitalization. They have returned back to their quality of life very quickly. And with some studies, most recently in 23 published in Annals of Surgery, some of them, despite the more expensive devices, given the longer hospitalization with open strategies, you're talking about equivalent costs, really no difference to the system. So there's clear benefit there. Now, as far as the durability, there's been several trials that have been done to assess this. The COBAS trial was amongst the first ones for it, where they compared bare metal stent to covered stent, and with this was a prospective randomized study, small patient population, but nevertheless important, because what they found was that there was clear superiority for longer lesions, task C and D, whereas in task B and A lesions, there was no statistical difference between bare metal. So clearly there's some benefit when you're treating longer lesions, and the use of covered stents allow us to achieve results that rival aortoiliac and aortobifemoral bypass. This study from 2020 as well kind of illustrates that too, where this was a meta-analysis that kind of looked at studies in the literature, this one with 14 studies, and kind of looked at all the covered stent grafts to kind of assess all of them. And with ICAST being the oldest, the one study there, it was studied the longest with 5-year patency rates that are up to 75%, with primary patency, secondary patency up to 95%. So pretty amazing kind of evolution, if you will, to get to treat task C and D lesions with these minimally invasive techniques. So there are upcoming studies. Obviously, we need more data to it, but the VBX Forward study is one that's out there as far as being done to compare bare metal to VBX primarily, but we clearly need more prospective long-term data for that. But I think it's become very clear that you get very good results with durability. And these were 2 cases that I had, one of which this patient had stents that were sort of undersized, and yet this patient was debilitated. He had severe COPD, and with Rotarex and being able to debulk it, and then with covered stents, we were able to get an excellent result with, this is a kissing technique, down with palpable pulses at the end. And then this patient with a CRAB technique, also a small, frail lady who was able to go home the next day with palpable pulses with no further rest pain. So it's pretty rewarding, and I think every item in the evolution of these technologies has played a role, but covered stents have been critical. So thanks for the opportunity.
Thanks, George. In the interest of time, we're just going to keep moving along, but I do encourage all of our participants to please put any questions you have in the Q&A, and we'll get to them at the end. Our next speaker is Nick Mawad. Nick joins us from the Department of Surgery at McLaren Health Systems in Bay City, Michigan, where he serves as the Chief of Vascular and Endovascular Surgery, as well as Chief of Staff and Chair of Cardiovascular Research, and the Vice Chair as well. He has a particular interest in advanced CLTI, PAD, carotid revascularizations, and venous disease as well. And today he's going to talk to us about the adjunctive re-entry devices.
All right, thank you, everybody. Really, thank you for the Midwestern Vascular for the opportunity to present here tonight. And I'm happy to be alongside my co-panelists. So look, maybe all of you have a lot of success crossing, but maybe I don't always get to cross. And sometimes I have to find an opportunity for a re-entry device. Here are my disclosures. And so this is the type of patients that at least I see in my practice. I know you all see in your practice as well. Complex aortoiliac occlusive disease, occluded iliacs at times, makes it very, very challenging, not easy, or desirable open candidates. And so when you want to deal with a CTO, as you can see to the screen right again, this is a different patient, but very similar as well. They're very common. They are very challenging. They can be extremely variable in the type of presentation or the occlusion. It's time intensive. We all know that. And I appreciate hearing Greg, who's willing to do 3, 4, 5 hours of doing some of this angiographic interventions, but some of us just can't or are not interested. Of course, there's a significant amount of radiation exposure to the patient ourselves and contrast exposure. And we know that the success rate's not 100%. You can spend a lot of time and not be successful. Furthermore, dealing with CTOs in particular, the lower extremity or aortoiliac segment, if you can't cross, you can't treat the patient. So that automatically eliminates your opportunity for reconstruction. Crossing them as well can cause complications such as perforation, dissection, and so forth. They, a lot of times, as was previously presented, have task C and D lesions, which are very challenging to manage. And of course, the type of cap, which I'm actually a fan of, will determine the type of intervention that you decide to proceed with. So briefly, and we all know this, but you really just have to think about it sometimes because it can be much more challenging to go central luminal crossing versus going subintimal than re-entering. A CTO itself can be subacute, acute, or chronic, and the composition is very, very variable. And it will really affect the type of choice of equipment that you need and the time that you want to spend on it. We know that more acute is thrombus or embolic in nature, but the longer it's been present, which tends to be the more of the patients we see with CLTI or advanced PAD, it can be rather fibrotic, high level of collagen, resistant to crossing, and particularly calcification, as I actually had to deal with a little bit today. So briefly, to choose a type of wire, and we all have our own wire that works for us. I'm a fan of the glide wire advantage, but that helps us allow the crossing profile that we want and escalate our therapy based on that. More importantly, as was discussed, a support catheter is necessary. I tend to use a Trailblazer, but you can move to CXI, which gives you more coaxial support in order to get the central luminal crossing, if at all possible. And this is obviously presented by multiple different companies, including Medtronic and Philips and Cook and so forth. It just kind of, you get to pick your own poison. Ideally, crossing in the lumen is, I guess, most desirable, but it's just not always possible, or maybe not always possible for me. So I'll acknowledge that. And so if you look at the type of plaque that is present or the CTO that is present, you can decide how you want to cross. And this is this IPOP discussion that came out of Western Michigan, whether it's easier to cross antegrade or retrograde, and whether the cap is concave and convex. And that kind of help you decide how you want to be able to deal with that. But just again, sometimes it's difficult to cross centrally, and you have to consider a subintimal possibility because it's not possible or that desirable from the point of view of time, contrast, and radiation. So in these type of situations, subintimal crossing is an excellent opportunity. You have a CTO in the mid portion of the vessel, and you're going obviously from proximal, let's say, to distal, even though you can do it from distal to proximal as well for retrograde access. And now that you're in the subintimal plane, you have to consider re-entering. And if you're able to do so with regular technique, glide catheter, or help you direct that, then great, but sometimes it's just not possible. So if it doesn't re-enter, what are you going to do? Clearly, you want to avoid extending the dissection plane for distally. That can make it much more difficult, of course, and you don't want to be too distal because you might lose more collaterals, even your outflow vessel. You can consider wire-based reentry with using a steerable sheath, or you can use a directional catheter, glide catheter, sharp catheter, or even a double curve. You can use sharp reentry, which I think we do sometimes when you're worried about spending too much time, or ultimately use a reentry catheter, which has kind of been something that I've been using a lot more early on in the interventions that I'm managing these patients. So here are a variety of reentry catheters, kind of from screen left to screen right. Outback, the B-back, that Cook had got the distribution for from Bentley, Pioneer, which is IVUS-based, Recross, et cetera, to this screen, right? I tend to use mostly IVUS-based reentry catheters because I'm very comfortable with IVUS, and it is part of my regular practice for managing patients with peripheral arterial disease. And there's a variety of data about this. I'm not going to belabor the point too much, but it's been supported with data over and over and over again. And you can restore true lumen crossing with the use of a reentry device after passing by the CTO. So much so that even you can consider using this from a pedal access, as was actually previously described. So sometimes it's just so hard to be within true lumen, they could consider going subintimal and re-entering, whether it's an antegrade or retrograde consideration. This is a diagram, a cartoon of a subintimal dissection, primarily with your 035 or 014 wire. Following that, You can advance in this particular image, it's the Pioneer catheter, which I tend to be in favor of because it allows me to identify the true lumen with intravascular ultrasound imaging. Following that, you advance the needle, you advance your 014 wire, and at that point, you actually get true lumen positioning, and then you can confirm that with further IVUS imaging. Of course, now that you're back in true lumen, you need to deal with the CTO, and so you can use a variety of adjunctive techniques as necessary. But almost always, you need to have stenting because you'll have too much recoil if you don't do something more definitive, such as a stent. So in the interest of time, I just want to share a case of mine. It's a recent case, 73-year-old male, Rutherford class 5 disease, a usual gamut of vascular comorbidities, and had poor inflow waveforms. Could not palpate femoral pulses. And in general, these type of situations, I moved to a CT angiogram. However, I'm going to show you the aortogram in this particular patient. So distal infrarenal aortic flush occlusion without really reconstitution of the femoral vessels. So my algorithm dealing with this is bilateral femoral retrograde access over a micropuncture technique, ultrasound guided. I tend to use an 035 glide wire advantage to help cross as much as possible, and then ultimately use an IVUS catheter. At that point, I'll de-escalate to an 014 wire and use the IVUS catheter at that level. But in these type of situations, it's very difficult, and so I use a re-entry catheter. And like I said earlier, I'm a fan of IVUS imaging. It allows me just to really see where I want to advance my needle and advance my wire following that. So re-enter the Pioneer catheter bilaterally, predilate the lesion, usually with a 4mm balloon. And at that point, I'll show you, take some further imaging. So let's see that. I guess it didn't show. Play that to the screen right. So now that I have wire access bilaterally, the goal at this point is to be able to manage that by pre-dilating the lesions bilaterally with usually 4mm balloons. And then after that, as was previously actually not described yet, but I tend to use shockwave lithotripsy to really get the gluminal gain. I've become much more courageous, much more aggressive. And then, as was previously described, I'm a big fan of covered stents, and that's what I ended up using. So 7mm VBXs bilaterally to get the kissing technique in order to maintain the lumbars and the IMA rather than covering it with a CRAB type consideration. So again, with a CTO, particularly in the iliacs, not wanting to open up, if you have a difficult time crossing, I very early on move to using a re-entry catheter and help to identify my true lumen. Again, for me, generally tends to be with IVUS imaging. As you can see from the screen left to the screen right, we're able to maintain this minimally invasive for a patient that we decided not to open, again, using a re-entry catheter. So just want to thank you very much for your attention, and I'm happy to take any questions.
All right. Thank you, Dr. Mawad. I always love it when I see former fellows doing things I know they didn't learn from us, because it always pushes and encourages me to try and look at new things and, kind of keep up to date with what's going on out there. So thank you, Nick. Next up, we have Dr. Lauren Masterson. Dr. Lauren Masterson did her general surgery training at Corewell, formerly Beaumont Health, and then did fellowship with us at Ohio State. After that, she went to Akron General, where she's currently serving as the chief of the Department of Vascular Surgery and also the associate program director for the general surgery program there. Dr. Masterson is going to talk to us today about drug technology in the periphery. Lauren?
Great, thank you. Let me share my screen here. I'm going to do the usual. Can everybody hear me okay? All right. So, so here, again, we're going to talk about drug technology in the periphery. Thanks again for the opportunity to speak. I don't have a disclosure slide, but I don't have any disclosures, but I'd welcome them if anyone wants to give them to me. Talking about the different drugs that are used, I'm going to be focused on DCBs and drug-eluting stents today. The drugs used in the periphery, this has been going on in the coronary world for 50 years at this point. Originally, these started with bilomus or sirolimus, which are immunosuppressants. Many of the balloons will have some sort of an excipient recipient on it to allow the drug to dilute and penetrate better. Urea is a really common one that's used these days. The most common drug we see on these balloons now is paclitaxel. It's a taxane chemotherapy agent with some anti-proliferative properties. An important thing to note too is that most of the drugs that are used are lipophilic, and therefore they're going to be attracted to the plaque. Taxane agents absorb fast, and they tend to localize in the subintimal space, which is why they've been really useful for these balloon and stent technologies. This is just kind of a close-up of, this is actually a coronary balloon, but this is sort of how the drugs are packaged. They're sort of put on the inside of the folds of the balloon. I think when a lot of us were first using these, when we were putting these balloons in, we're rushing to get the balloon in, because as soon as you touch it, it's going to start delivering the drug, but they've gotten much better at the packaging. So now it's kind of within the folds, and once you inflate the balloon is when the drug is dispersed. So you don't have to be quite as speedy getting these balloons and stents in and out as you used to. I'm not going to bore you to death with 1,000 Kaplan-Meier curves, but there's been a lot of studies out there that show that the drug technology has higher patency rates and lower rates of reintervention than the naked balloons. This particular Kaplan-Meier is looking at amputation or risk of reintervention, and over time, the drug-coated devices, both balloons and stents, have proven to have a much higher patency rate. I could show you 1,000 of these, but I won't, because nobody reads them. So this was a big study that looked at, they did a meta-analysis of a bunch of the randomized trials, and most of these, it's important to note, are done with femoral popliteal lesions. There are some studies I'll mention later for infrapopliteal, but the vast majority of these studies have been done on fempop lesions. I think those long SFA occlusions. And there's been a lot of studies that have shown, again, that your target lesion revascularization is improved with the drug-coated balloons long term. So when do you want to think about using them? Short lesions, consider a DCB only. Let's say you have a short CTO, it's less than 4 centimeters. This would be a good option for DCB. Longer lesions, which in the literature are described up to 15 centimeters, consider stenting. Now, the European study that came out, I think, about a year ago, they're sort of classifying long lesions as up to 25 centimeters. So some people are doing entire SFAs. I'll show some pictures at the end here, which is what I did this morning, which was pretty close. But longer lesions in most of our literature are still up to about 15 centimeters. Or if you have poor results after angioplasty, consider stenting at that point. Something that I didn't include in the considerations for use is the dual antiplatelet therapy that the patients all need to be on after placement, which is another thing to consider. If you have a patient who can't take dual antiplatelet therapy, this is not the right choice for them. So something to know before you go into your procedure is whether or not they'll be able to take those drugs for the time needed afterwards. Most of the studies, again, are in fempop lesions. Remember that we have about 50, 60 years of studies based on coronary disease that show really excellent results, but in the periphery, fempop is the most studied lesion, and this is still where they're primarily being used. The infrapopliteal lesions have been studied with limitations, and I even put a little asterisk there because it's important to note that the studies where they look at drug technology for infrapopliteal lesions are 1, critical limb ischemia patients. So these are patients who are at risk of limb loss, and most of these patients are not bypass candidates. So this is really a salvage procedure. And in those cases, the results are promising that there is a longer amputation-free rate with the drug technology, again, for the infrapopliteal lesions. But remember that infrapopliteal lesions in a claudicant, this is not okay. This is not what we're talking about here. This is critical limb ischemia for patients who are not bypass candidates. Available products, really every drug companies, every major device company is making these. You have your options of 0-1-8 wires, 0-1-4 wires, 0-3-5 wires, stents, balloons, different French size systems. You can pretty much, every company is making these days. The Zilver stent I used today, it's pure coincidence, I swear, not sponsored, but I did use it today. But they do come in a variety of sizes and lengths. It's what we keep on the shelf. It's what we use the most frequently. And to bring up this, let's remember back in a time before COVID. In 2018, this paper was published, and this caused a lot of stress. Let's say this was a study that it was a meta-analysis published in the American Heart Association journal that basically looked at these long-term results, and what they found was that while it does reduce the need of reintervention and increases amputation-free survival, there was a risk of death in these patients after procedures. And there was no common cause of death. There was really no kind of finding that said, like, this is why these patients are dying after they receive the drug-coated technology. And at this point, a lot of people pulled back. So when this was published, a lot of people pulled back from using the drug-coated systems because it wasn't clear what the safety of these devices were. This study has been attempted to be replicated, and it's important to note that these results have not been replicated. So when this came out, a lot of people, like I said, pulled back, stopped using them. Some places even took them off the shelves. But the FDA came out and released a statement about 8 months later that said the benefit does outweigh the risk, and for these paclitaxel coated devices, and that really there again, we just don't know why that the results were of that study. We don't know why these patients were getting this increased mortality. So the FDA released a statement that they are safe, but you need to have a informed choice with the patient. And, some people put that on their consent. Now that it's been, 4 or 5 years after this, again, the results have not been replicated. So most people think that was sort of a one-off. The studies have shown that it's very safe now, and we have never been able to find that same result. When you're thinking of using these DCBs or the stents, some things to think about is it's always about case planning. I have a CTA in most patients, so I will know what sizes of balloons and stents I'm being prepared to use. You want to prep your vessel, especially in a CTO, before you put your drug-coated device in. Prep your vessel with a smaller balloon, 0.5 or 1 millimeter smaller than the vessel. 1-to-1 sizing for the balloon, for the stent is usually good. You want to shorten the transfer time. Again, most of these are made in a way where that's not as important as it was before. You're not trying to get everything in there in 30 seconds so the drug doesn't start deploying. Most of these are better at that. And then each manufacturer will have specifics for the prolonged inflation for the balloons. 3 minutes is, I think, pretty standard for these. This was, again, just a case I just happened to do this morning, so I put these images on here. I tried to line these up nicely, but this is a gentleman who has symptoms kind of consistent with rest pain. His ABI was 0.5 on this side. His SFA was occluded from the kind of the mid to distal portion. This is his common femoral is profunda. In these pictures, I'm not sure if they're coming across that well. And then he reconstituted right as above knee. This is an angiogram we've all done 100 times. We've all seen this patient 100 times. This is not somebody I would necessarily consider bypassing as my first choice, just because of his other comorbidities. But I was lucky today. There was a little wisp of an SFA at the origin there, and we all know if there's a wisp, there's a way. So I was able to get through the lesion. Was able to get through. I used just a quick cross and a glide wire. It actually went pretty smoothly. Confirm your true lumen. I pre-dilated with a balloon that, again, I had pulled off from the shelf, kind of based on his preoperative imaging. And then this was post-angioplasty. You can see there's dissection planes. There's still a lot of residual disease. This is exactly the candidate that you want to use one of these stents on. So then this is his post picture. I ended up using 3 stents. I ended up stenting totally about, it goes all the way up. You can't see it on that picture, but it goes all the way up to the origin of his SFA. But I ended up using, I thought I had the sizes in here, but I do. So I ended up treating about a total of 25 centimeters today with the stents. And if you actually go on the Cook website, they will have actually a little calculator you can use, which was kind of fun. I was playing with it today. But you put in your lesion length, his age, smoking status, runoff, and they'll tell you what the patency rates are. And according to that, this gentleman should have about a 4-year 90% patency rate after this treatment today. So he had palpable pulses at the end of the case, went home a couple hours later. So pretty good results overall. Takeaway is that these have been well studied. The DCPs and the stents have been well studied. They're really safe and effective, especially for fempop disease. Consider them the balloons for shorter lesions, stents for longer lesions, or poor response to angioplasty. Remember that there has been some limited studies in the infrapopliteal lesions, but again, for patients who are not bypass candidates, and we were talking about limb salvage as well. But again, it's been safe. People have been doing it for years now, and we've been getting great results. Easy peasy.
Thanks, Lauren. That was great. So again, everybody, encourage you to put your questions in the Q&A and we can answer them live now. I'll start out with a question for you, Lauren. Do you always pick drug-eluting stents if you're going to stent? And if I guess it's a 2-part question. If you're planning on stenting primarily, and if you've already used a drug-coated balloon, what's your paradigm if you have the need to stent after you've angioplastied?
I'm stenting a particularly long lesion like the one today. If it's the majority of the SFA, I do usually plan on using the drug stents, just because the patency rates are better. I do make sure with the patient that taking the dual antiplatelet therapy, because that's important, is the medical therapy afterwards, that they can maintain that therapy. We are not in the habit right now of checking Plavix resistance in patients, which might be another question. We are checking it for all of our TCARs. We're not necessarily checking it for our peripheral patients at this time. We've kind of considered putting that in our sort of our pre-testing. But for the most part, I'm doing Plavix and aspirin afterwards. If I use a drug-coated balloon, I don't have the results that I want, I would then put probably a bare metal stent in afterwards. I'm not double loading with the drug products at this point. Typically, if it's a shorter lesion, I'll try balloon first. I will probably do a drug-coated balloon and maybe go to a bare metal stent. But the long lesions, especially like those completely occluded SFAs, those are great candidates for the stents.
I tend to follow that too. Like Masterson, if it's going to be a CTO, pretty regularly we'll use the drug-eluting stent in those instances. I think, drug-coated balloons have their place in some of these lesions, maybe more focal things, or maybe certain specific locations that you don't want to maybe leave a stent behind. But again, the longer CTOs, I do think the patency tends to be a little bit better with the drug-eluting stent. There was a question earlier asking about for aortoiliac occlusive disease, Dr. Ponticus, if you ever would consider use of other covered stents like a stent graft as opposed to just balloon expandable stents, and if anyone else in the panel has experience or has sort of used that technology instead of traditional covered balloon expandable stents.
Yeah, so I'll use, if there's an aneurysm, I will use that without any issues, and obviously treat the iliacs with covered stents on the way out. For occlusive disease, I would say with dissection, I'll also use a standard graft, and then the other is if you have kind of disease that goes closer to the renals, I consider it, but most of the time, that's where CRAB kind of helps. And I mean, you have limited workspace, and honestly, if you're using aortic stent grafts, you're going to be, those don't have the radial force, so you're going to be placing balloon expandables within that anyway. So it's a bit redundant, but I would say I'll use those. I'll use stent grafts, particularly the low profile Gore conformable is what I've done for some of these patients that have either dissection, because I want to give them a more long-term durable repair. And there's a lot of data obviously for aortic stent grafts that have been done for years. So I'll use that and kind of reinforce those with balloon expandables on the inside. I don't use the AFX though. That device I don't.
Greg, I have a question for you about your access point. So I feel like if I'm able to get access, about 90% of the time I can cross the lesion retrograde, and it's usually very, very simple. The issue that I usually run into is having like a little bitty short segment of artery and then trying to navigate around the ankle. You made an interesting statement about how you can puncture an occluded tibial. Tell me how exactly that would work.
So I think if you're, access, the long view on ultrasound, I think is helpful, especially with these calcified tibials, getting a needle in there in the same way that, I've seen anesthesia navigate under ultrasound, getting a catheter into a vein, not just tracking the needle to puncture into the anterior wall of the artery, but tracking the needle longitudinally down the artery. I mean, if I feel confident that seeing that heavy calcification above and below, I've got the needle into the lumen, then especially, the description of like different types of plaque earlier was useful. Like, it could be occluded, but still have relatively soft thrombus or, acute chronic thrombus in the lumen. And so if you can get a wire into the lumen, then I've found that sometimes that will track very easily up through the occluded artery, and then that will often re-enter the patent, whether it's the PT proximally as patent or whether it's re-entering the patent popliteal up there. That can be useful. Does that answer your question?
Yeah, I guess I still struggle with you're puncturing an occluded artery, then where's it going to go, right? Where's
right.
your
So what I was thinking is,
right.
So then either I think of that as then I'm coming back from another access antegrade down the same vessel, past that occluded segment and like into the foot, to find, it's occluded at the ankle, but then the AT is occluded at the ankle, but the DP is patent or something like that. Or I was thinking about it as, the AT is occluded all the way down. It's not providing any significant perfusion to the foot, but using it as an access point, then I'm not trashing the PT, that's the dominant runoff to the foot. I have, an access into the occluded artery, and then it can at least help me get through the popliteal and SFA lesion that I'm trying to treat.
Yeah, that's a good way of thinking of it.
All right. How are we doing on? We got a couple minutes left, or are we kind of running up against the clock? But if we got a quick question for Dr. Mawad related to the reentry devices. So I've crossed the CTO of the entire SFA. I went subintimal. Now I'm at the popliteal. Do you ever find it challenging to advance that 6 French device all the way through that log subintimal plane? Or if so, are there other tips or tricks that you have in getting through that really long CTO and then using that reentry? Because sometimes I can't even get a balloon to track through that path.
No, you're exactly right. Actually, I used actually 2 of them today. I had a day of really bad CTOs and calcification, and so actually I just pre-dilate. And so over an 014 system, or pre-dilate with a 4 mm balloon. I mean, as aggressive as necessary, and then re-enter. So that just tends to be what I end up doing. It tends to be successful, I'd say, over 95 or 98% of the time. Now, I'm not saying that I go to a re-entry device immediately, because there is, of course, a cost to the health system and so forth. But you try, you do all the regular stuff. You escalate your wires. You go to an 035, or you might de-escalate. You do all the things that you're supposed to do. But after a while, it's like, okay, this is not going to work. And so instead of spending another 45 minutes and opening 15 other devices trying to try something, I tend to move to a reentry device sooner rather than later. It tends to be more commonly in the iliacs for me, rather than in the peripheral. I agree with Greg and George and Lauren. Like, there's other alternate access opportunities. You can come back, you can snare, things like that you can do. But for the iliacs, after a while, I tend to just go to a reentry device, and then you're going to stand across that anyway.
To follow on to that, Nick, I had sort of question about how you identify the right site for reentry. Ultrasound will show you where the lumen is, if you're using that. So that's great. Do you take the first spot where you see some flow in the artery? Are you looking at calcium? And speaking of calcium, I've found that the needle on the ultrasound guided device is not as strong at puncturing through the vessel as some of the other reentry devices. How do you handle that?
Yeah, agree. I mean, great questions, and I think there's multiple different answers. The more challenging part, at least for the iliacs, I try to preserve the internals, so I try to go as distal as possible. But of course, you want to regain true lumen whenever you can. So that tends to be the more challenging part for me. As soon as I can regain true lumen, I tend to take that, because I'm going to stent distal to that anyway. But of course, if there's a significant plaque shift or something more proximal, then at that point I'll consider going a little bit more proximal. What I don't like doing is going subintimal all the way, and then avoiding just because it's easier, or your initial wire keeps in that subintimal plane. I think it's important to re-enter true lumen, because we all know that once you remain true lumen, it tends to be better anyway. So I think I'll go as soon as I can regain true lumen, assuming that something more proximal is not going to cause some inflow, abnormality. I think that's how I generally do it.
Well, great. Well, thank you again to all of our excellent panelists today. This was a really interesting discussion. Also, thank you again to Cook Medical for sponsoring today's webinar. Our industry partners are incredibly critical to the success of our New Horizons webinar series. We really appreciate the support. Stay tuned for our next webinar that will be hopefully arranging soon. And again, thanks everybody. Excellent job tonight.